The title of this panel is Impacted Community Members Speak Out Against Assisted Suicide. This is another issue that we believe it is especially important to hear from those who are most impacted by it. In recent months, international attention has been brought to Canada's controversial euthanasia laws. For this panel, I am joined by people who have a vested stake in this issue. First, we have Nicole Scheidel, who is the Executive Director of Canadian Physicians for Life, who are also the sponsors of this panel, and we are very grateful to get to work with. With her is Dr. Leonie Herx, who is a specialist palliative care physician in Kingston, Ontario, associate professor and division head of the palliative medicine at Queen's University, clinical director for palliative care at Providence Care Hospital, chair of the Royal College of Specialty Committee in Palliative Medicine, and a past president of the Canadian Society of Palliative Care Physicians. We are also joined by Dr. Heidi Jans, who is a core faculty member and associate adjunct professor with the John Dossiter Health Ethics Center at the University of Alberta. Her areas of specialization include disability ethics, critical disability studies, and research-based drama. She is also an active disability rights advocate at the national level. And finally, we have my friend Taylor Hyatt, who has worked in disability policy from 2015 to 2020, including serving as advisor to a member of parliament. Taylor is a former member of the Euthanasia Prevention Coalition's board and the Council of Canadians with Disabilities End of Life Ethics Committee. I'm sorry, I'm having issues reading today. All of these individuals have a different perspective and a different area of expertise on this issue, so I'm excited to get started. First, I'd like to give an opportunity to Nicole to just set the stage for us. For those of us who maybe live in America or elsewhere and haven't been paying attention to the MAiD policies in Canada, what do the current policies look like as far as barriers, conscious protections, etc.? Just give us a brief outline of what is the situation up there.
Sure. Thanks a lot, Herb. I think it would be interesting maybe for people to step back to, we had a Supreme Court decision with Sue Rodriguez where the Supreme Court said no assisted suicide in Canada. It doesn't really fit within our charter. And then 4 or 5 years later, they changed, right? And all of a sudden it was okay as long as we had, I'm going to just read exactly what they said because I just find it so striking that a carefully designed system imposing stringent limits that are scrupulously monitored and enforced. So that's what we were promised. That's not what we have. And I know that the other people on this panel will get into it, but we started out with the legislation in place. And as soon as it was in place, it was challenged and chipped away at the legislative level, but also at the level of the professional bodies that are governing doctors. So now there's no conscience rights protection for doctors. In Ontario, there is an effective referral requirement, so you have to participate. You can receive euthanasia as long as you're over the age of 18, and it seems to be if you find a doctor who says that they agree with you that your life is intolerable, you can receive euthanasia, whether you have a manageable disease like diabetes, whether you are of a certain age, like 75, and all of a sudden you decided that that's acceptable. And just last week, we had a doctor from the College of Quebec suggesting that we should euthanize infants who are under the age of 1 if their parents want to euthanize them because of, I mean, this is the thing is, right? Like they hold up hard cases, but as we know in law, hard cases make bad law. And they hold them up to stir up everybody's emotions because they are hard. It's hard to deal with someone that you love who's dying and suffering. But then it opens up the gates to attacking all sorts of people with vulnerabilities. And we see, and I know that Taylor and Heidi can speak to this, and Leonie can speak to what's happening in the prisons because Kingston has a big prison population as well. But as soon as you have people who are vulnerable, and they see that as their way out. So you back them into a corner, you don't give them proper social supports, you make their lives miserable, and then you say, but hey, you can have euthanasia and the state will fund that.
I think,
Thank
can I
you.
jump in and add one thing?
Please.
I think what's really interesting, it's not interesting in a good way, but what's very different about the Canadian legislation compared to other countries is that patients only have to be told about what their other options for care are. They don't have to be accessible even, or to have even tried them, whereas in the other jurisdictions, they have to have exhausted all other options for care. And here, someone can just say, I want to die, and not have tried anything, and it could be the only quote-unquote treatment that they receive. And then the reality is, and I'm sure Taylor and Heidi and Nicole will also speak to this, is we have very limited access to home care, disability care, adequate resources to help people live fully and have meaningful lives and live with dignity, but we have very easy access to have someone's life ended. So not enough medical assistance in living, and very ready access to medically administered death.
Yeah, and actually, I'm just going to jump in with one last point on that. And other countries, it is supposed to be patient initiated, but in Canada, that's not the case. And we just had a recent event with a veteran who was trying to seek treatment for PTSD, and his service worker, so not even his physician, hounded him about getting MAiD. He told her several times, stop, I don't want to hear about this. And she kept, like, it's better than blowing your brains out. Like, what is that to say to somebody who is suffering and in a challenging position, suffering from PTSD? And so what we see in Canada is there's a lot of, I would say, coercion, as this is the easiest, quickest, cheapest way to take care of the problem of your life, because your life is somehow kind of complicated, or you're not dying fast enough for me, so I'm going to like push you out the door.
Thank you. I would like to now move on to both Taylor and Heidi. I've been really lucky to have read some of both of your writing about this topic, and I really appreciate the perspective that you're able to bring. Taylor, first, can you tell us a little bit about why you are particularly invested in this issue? And then Heidi, same question.
It's hard for me to go back to the beginning of my advocacy right now, because as we chat, I'm kind of in the middle of a living practicum for my advocacy right this second. You'll notice I'm not at home right now. That's a hospital. Tim Hortons behind me. Yeah, just to know that people look at lives like mine on an average day and say, you know, living in a world that's not accessible to me, living in a world that I require mobility devices, and I'm dependent on, to some extent, other people's kindness to navigate. That's not a life I want to have. That cuts to the heart, you know? And right now, for those of you who don't know, I was in a collision with an SUV a month ago, and I'm in rehab and trying to work my way home. And I'm living right now in the limitations of an institution, and with bodily limitations that are often cited as people's reasons for finding the end of a needle attractive. I don't have control over a lot of my life right now. Those supports that are offered to me are often provided in a way to make staff's job easier rather than be most effective, and I don't want to use the word autonomous, but appropriate for me. And yeah.
Thank you. Heidi, same question. I'd love to hear your perspective, especially related to disability rights.
I'm The first case that activated me in the way of just getting involved into disability rights was the Robert Latimer case in 1994. The basic premise of the case is that Robert Latimer had a daughter who had cerebral palsy. She was nonverbal. She was 12 years old when Latimer put her into his car. In his truck. And gassed her to death. A significant portion of the media at that time and also the public were in total agreement with his contention that he did what he did to prevent her suffering. Us in the disability rights movement, we recognize that he put her out of his misery. And since that time, for the past 30 years, we have been fighting to not end up where we are now.
Wow. Thank you. My next question is for Dr. Herx. Can you please tell us how your field of palliative care has been impacted by this new status quo in Canada? And maybe what can we learn from the field of palliative care about end of life?
Those are both really good questions. So I think one of the issues is that palliative care has been fighting stigma and to kind of demystify the public and other healthcare professionals that we don't hasten people's death. In fact, we have excellent therapies and interventions to help people, again, live fully. So to address all those different components of what a person experiences in suffering, because they're really interdimensional and emotional, spiritual, existential, physical, and it's very difficult to tease out someone just has physical suffering. The human experience isn't in boxes, right? And so palliative care has developed over the last 40 years quite exquisite expertise to be able to address that. And when someone expresses a desire to die and thinks they'd be better off dead, that's often a sign of unaddressed past trauma or suffering or grieving or lamenting, facing the possibility of their own death and what their life means. It doesn't mean that they want a lethal injection and want their life over. And so palliative care really responds to that and comes alongside someone and really digs deep to try to understand and, how can we best help this person get back to living? And not enough people are getting trained in even basic how to provide a palliative approach to care and help people, get the supports they need and get expert palliative care involved when needed. So we need to really improve education. But now MAiD has kind of become, like Nicole said earlier, the easy out. So there's not enough access to palliative care and other supports to live. And out of a lack of education and a lack of resources, MAiD is now being offered at a first expression of a desire to die or a death wish, which is not necessarily they're asking for their life to be ended by lethal injection, right? So it's become almost like this knee-jerk response to say, oh, they're talking about wanting to die, they must want MAiD. To the point where literally if I have a person before me who's actively suicidal, has all those red flags for committing suicide, access to a weapon, a plan, all those things we used to, bring someone into hospital against their will for to help them get back to living. Now the response to that is, oh, just give them the MAiD phone number. And so it's really changing the culture of caring and restoring health, which is the foundations of healthcare. And so it's just, and then as Nicole said, to have anyone now diagnosed with a potential, a condition that makes them potentially eligible for MAiD, which is pretty much if you're 18 and over, anything right now except mental illness as a sole diagnosis, which will change in March 2023, you're meant to be offered MAiD as like one of the standard routine options for care. So I think it's just that there's a lot of problems and a lot of risks for coercion, and a system that's strapped for resources and doesn't have people getting good education in how to address suffering. So I think palliative care has lots to offer, and even I think we need a community response to palliative care to help people feel not alone and that they matter and that they have a dignified life. In that, even if they have lack of healthcare resources, I think the community and all of us can play a big role in addressing some of these gaps.
Yeah, thank you. I want to read a comment from the chat that I think just perfectly illustrates what we're talking about here. This is from Gabriella. She says, "It blows my mind how I can get suicide assistance because I'm disabled, while my able-bodied peers get suicide prevention. This is ableism at its finest." And I think that just illustrates exactly what we're talking about here. And I appreciate you sharing your perspective in the chat, Gabriella. And so I guess my question related to that is for Heidi. Do you feel as though people are listening when you speak and write on these issues? Do you feel as though you're making an impact and people are concerned about the disability aspect of these policies?
It depends on the audience, frankly. Speaking to Canadian policymakers, no. They don't listen at all. My perspective interferes with their physiological worldview. It goes against the way of how they see the world. But if I'm speaking to a general audience, and telling about my own personal experiences with ableism and how it therefore connects to me, they're often shocked. Some of them say, I never knew that. I never knew that that could happen in Canada. It's all well and good. Other people say, well, it's all well and good that you're against MAiD,
Yeah, university.
You're a university professor.
Blah,
Blah, blah, blah.
blah.
You have a good life.
Well, I'm doing this. I do for
But
people.
what about this other poor person
That's
who's suffering? There's still a huge disconnect there.
Thank you. Nicole, I think I have the same question for you as someone who's been involved in advocacy on this issue with Canadian Physicians for Life. I think from the outside looking in, it just seems like a disaster. Every time there's an update to the policies in Canada, it is negative. They're removing barriers. It's becoming worse for patients. What do you see the sort of future of advocacy on this issue looking like? I think someone asked, like, where do we go from here? Because some of these barriers that we talk about in the U.S. to assisted suicide, to us, we talk about as, they're not barriers at all. Whereas I'm almost like, well, I want them in Canada. We need something there. Almost anyone can get assisted death. So I'd love to hear your perspective, sort of on the policy going forward on this issue.
Yeah, I think it's going to get worse before it gets better. I think once suicide for mental illness becomes okay. So the reality is that most people don't have someone like Heidi or Taylor in their lives. They don't come across someone like that. So they don't know how to react. Like, they don't have that experience. So they don't see that they value their lives. So they imagine that their lives must be horrible. But all of us have someone in our lives who has struggles with depression or anxiety, right? Like, I've had to take my daughter twice to the children's hospital because of harming herself, right? She's under 18, thank God, right now. But in next year, she'll be over 18. So what happens then? So then all of a sudden, if you're taking your kid or your young adult to the hospital and then they can choose death and it's out of your hands, all of a sudden, everyone in this country is going to be face to face with that. And they're going to know people who lost their lives that way. And I think, like, I'd love to be wrong, but I think that's what's going to take for our country to wake up, because everyone is just like, well, it's, I want it for me. If I get to the point where I'm suffering so badly and I want an easy exit, it should be available to everybody. And I don't really care who gets hurt in the way. So I'm not really that concerned about people with vulnerabilities, because then it's like, I don't want it to be limited for me. That's the feeling I get, particularly from some of the senators who want it for themselves when they're ready to check out, right? Like, I don't know. Look, you guys were there. You know what it's like talking to some of those people. It was pretty frustrating.
Yeah. Thank you. Does anyone else have a comment on that question? No. All right. The next one we have from the chat is, how do you recommend talking with family or friends who live in a place where euthanasia/assisted suicide/MAiD is legal, and they are considering that as an option, especially if they have worsening chronic conditions or something else? How do you actually talk about this on the interpersonal level rather than, politically? Dr. Herx, do you have a response to that?
Yeah, I think one of the things is to really help have people understand what it is, because that's often, in my clinical experience, people will say they want MAiD, but they actually want a peaceful death if they're someone who's, got palliative care needs and has a progressive life-limiting condition. And they just want to be comfortable and not do things to unnecessarily prolong their life, right? And so helping people understand those are all really important ethical choices you can make if you don't have to have all these unnecessary medical interventions that extend your life at all costs when they're not helping you live well. And I think that's a big thing, because one of the things kind of driving the original push to the legislation is that, people have all this terrible suffering at the end of life, which but they don't actually know about their palliative care options. So I think education to help people understand like what palliative care is, what normal dying and death look like, and just to again just remove that fear, and that there's no need in the 21st century for anyone to have uncontrolled symptoms while they're dying. People die very comfortably. I've, in 15 years of doing palliative medicine, not had someone that I couldn't keep comfortable, but it's often a lack of awareness and understanding about how we can help you live well, and what resources are available to help you in getting you hooked into those resources. So I would also clarify with them what they understand about assisted death, that it's a lethal injection that immediately ends your life in Canada. That's the majority of it, although assisted suicide is available, because people don't understand that. So that's always the first place to start. I'm sure Taylor's nodding. She has things to add, I'm sure.
Please.
I think the most helpful thing I can add here is that it's, as I was saying to start with, it's not always or only the interpersonal dimension. While it is really important to affirm a person's worth and their sense that they matter when they're in crisis, what everyone, the average person on the street, the policymakers and beyond don't realize is that it's a systemic issue. All the one-on-one crisis intervention in the world isn't going to make self-directed attendance appear overnight, isn't going to make accessible housing appear overnight. And so you've got to tackle it from two different angles if you're really going to make a difference here.
Mm-hmm. Yeah, I'd love to get. Oh, sorry.
Another thing that people really need to know is there's a common misconception of you have a disability, therefore the state takes really stinking good care of you. They don't. It's not as if your accessible housing is automatically provided. It's not as if you live on provincial or state disability supports, you are drowning in funds. In Ontario, it's about $1,100 a month to cover your rent, your food, your groceries, your transit, your entertainment. That is plunging a lot of people into dire poverty, and they're reduced to eating, half a potato a day or, a couple of spoonfuls of food a day just to ensure that everything else is paid. We have to smash the idea that we're freeloaders who are already taken care of. That's not the case.
Thank you.
Yeah, I just want to follow on what Taylor said, because I think it's a really important point. And I know that Leonie and another physician had organized general rounds, and they had some individuals who lived with disabilities speak to the physicians. And I had the privilege of attending those rounds. And to me, it was eye-opening. I'm sure it was eye-opening to many of the physicians. I think that Taylor's hit the nail on the head. Many people are just they're not aware. And so that's a big part of it, is that it's incumbent on all of us to raise those issues, that we need to care for the people in our midst so that they can live like human beings.
Yeah, thank you. Related to that, a question in the chat from Anonymous reads, what practical actions can we include in our life to do more to confront ableism and rehumanize disabled folks like us, like me, says the commenter. Heidi, I'd love to hear your response to that.
Just calling out
to start calling out ableism when we see it.
We actually have a lot of patients on the countries.
We rightly have
a lot of attention we take to racism. A lot of attention.
we rightly so give a lot of attention to racism.
Both Canada and the US.
In both Canada and the US.
So, media
But when was the last time you heard any media use the term ableism? That needs to change. And the only way of how this is going to change the only way of how it's going to change on a large scale is if people start seeing it and start speaking out against it.
Thank you. Yeah, and I would definitely echo that. Not only do we not talk about ableism and name it as such often, but almost never in the context of medical aid in dying is that perspective brought out, unless it is by actual disability self-advocates like yourself, and like I'm learning many people in the chat who are also sharing their perspective, which I'm not very surprised by at a Rehumanize conference. But I do want to quickly share our president, Beth Fox's comment that she made in the chat. She's a disabled woman, and she says, "We don't need aid in dying. We need the resources to continue living." And yet again, that is exactly what we are talking about here. Taylor, I'd love to hear what you have to say.
I just want to piggyback on Dr. Jans's remarks for a second. Another thing that we need to do when we're calling out ableism is reframe how disability is looked at overall. People will look at Dr. Jans and I and say that our bodies are the failing, not the building that doesn't have a ramp in it, not the medical environment that isn't equipped to help me, not the nursing home that's the only accessible environment that someone is able to go into when they acquire a disability due to age. It means that we need to examine ourselves, and nobody wants to do that, unfortunately.
Mm-hmm. Thank you. Another question from the Q&A, and I think this is a great question because this is one that I have too, from Stephanie Commission. How can we effectively interact with people with disabilities or chronic illnesses who say that it is actually ableism when we able-bodied people tell or expect them to continue living if they would otherwise seek assisted suicide or medical aid in dying? And so as an able-bodied person, we have no right to speak to them on the topic. How would any of you respond to that? Anyone want to try? Nicole?
Well, I think the desire to die comes from a place of despair and feeling like there's no meaning anymore for your existence. And so there is a certain inability to see, in some ways, to see reality. And I just think about the people that I love who are, have dealt with like serious depression, as opposed to, I don't have anyone in my family that I take care of who has a serious physical disability, but I do have people in my life who really struggle with depression, and for them, that desire to die or suicidal ideation comes from a place of darkness, and that what they need is help. They don't need someone to say, oh yeah, right, let's help you out the door. They need someone to fight for them when they are too vulnerable to fight for themselves. And I guess that's how I would perceive, and Taylor and Heidi can correct me if I'm wrong, that someone who is like Nicole Gladue or Jean Truchon, that they're in a place where they need someone to say, yeah, actually you are worth fighting for, and I want to fight that you have the right to live well. Anyways, okay, so Taylor's raising her fingers, Heidi's raising her arm. I'm sure they have a lot to say.
Taylor, you first.
Oh, okay. I was just going to say, in the circles that Dr. Jans and I run in, we talk about the importance of peer support, of being well connected with disability as a community and an identity, and having people who are walking a similar path to you. I mean, to the other three lovely folks in this chat, you're all great, but there is a point you reach where that argument has weight. There are some places where someone who does not have a certain condition can't go. And you need to see somebody who has been there and been able to thrive in order to see it for yourself, too.
Just going back on this
Just to go back to Nicole's comment. She mentioned the Quebec case that got this whole thing started. If you go back and look at the testimonies, the suffering that the two individuals said that they had all comes down to the fact is the fact that they were forcibly institutionalized or afraid that they were going to be forcibly institutionalized. And that was shown as a part of their disability when it wasn't. It was all about how society treats people with disabilities. No one and nobody in the court ever questioned it. And we see it happening over and over and over again. Now, when somebody with a disability say that they want to die, it's seen as a rational choice. But in most cases, they're just tired of fighting to be alive.
Thank you. Yeah, I think in response to Stephanie's question too, because I've heard that it's actually ableist to tell a disabled person who may be suicidal that they are wrong, that I believe their life is worth living if they've come to an alternate opinion about that. When the same could be said about anyone who is suicidal for any reason. They've come to the conclusion that their life is not worth living, and regardless of the circumstances, I'm likely going to disagree with them that they have value, and that I think that we should do whatever possible to save their life in that circumstance. And on the ableist angle of that, I also point people to Not Dead Yet is an organization that talks about this a lot. I know there's a chapter in Canada that Taylor has been involved in. But they are a disability rights organization based here in the US. And they point to the fact that, at least in the United States, all of the major disability rights organizations, all of the national disability rights organizations that take a position on assisted suicide and are run by disabled people oppose assisted suicide, and it's oppose the expansion. And so I really, I want to respect people, and I want to take seriously the concerns of people who are experiencing hardship and illness. However, we should not ever let it get away from us that what we're seeing here is, an attack on disabled people, and on the way that we view people with disabilities, old age, chronic conditions, anything less than the idealized, able-bodied adult. And so I think we're running out of time. I have another question here from Gabriella again. She says, here in Chile, where this issue is currently being discussed, people seem to really equal a peaceful death with an assisted one, which makes her suspect that there is zero awareness about palliative care. How do we fix this? Dr. Herx, I think that this is perfect for you. How do we do community education about this?
Yeah, public education, I think it has to start at the grassroots level, and just, start having conversations about what matters to you in your community centers and your church basements and your, wherever you can get groups together. What we need is just education on what normal dying and death looks like, because it is most often comfortable even without an expert palliative care. And then what is palliative care? That it's not just at the very end of life. It's actually, the earlier palliative care gets involved, the better to help people live well, so that you don't get to a point where you have, such intolerable suffering. So there's a really cool international movement, and I know the other panelists have heard me speak about this before, called Compassionate Communities. It's an international movement that came out of Australia, actually, and then spread to the UK. And it's kind of like a public health approach to palliative care, that palliative care is everyone's responsibility in the community to care for one another and talk about dying and death and what matters to you and your wishes and goals. But there's really cool resources. They're all free, that you can help for your community groups to look at, what compassionate communities means. And it's things like, sunshine calls, where people who live in isolation by themselves and are lonely, where you call them in the morning and you give them a positive start to their day, or they need to be driven for groceries, or, just social connection for people who are feeling depressed or demoralized. There's so many really practical little things that we can all do for one another, to care for one another, that the Compassionate Communities movement, you can easily spread it because of the constructs are all there, and some even practical suggestions of things to get going. So I encourage you to Google it, or maybe you could send it out. I'm not sure about Compassionate Communities. It's all over the world now.
So, and I want to just jump in here because I know she's talking about what you can, like the communities, but also from the physician perspective. So we do a lot of education for physicians because physicians do not get enough education about palliative care. A lot of them don't even know how to use those tools or even that they exist, right? So it's important that they're well educated. A cool thing that we're doing at our conference in 2 weeks is we have a physician talking about neonatal palliative care, and he's created a family physician navigator advocacy program to help family physicians help their patients navigate through challenging situations. And so I think there's a lot that physicians need to be made aware of, because palliative care is not it's not a required part of training as a doctor, and it really should be, because everyone is going to need it at some point, right? Every patient that you touch is going to need some kind of palliative care, and so it does need to be more widely taught in the medical schools.
Yeah, thanks, Nicole. I was focusing on the communities, but also just noting that it's not like palliative care does not hasten people's death is another misconception. People are scared to have palliative care involved because they think you're going to give someone large doses of morphine and overdose them and shorten their lives. That's not palliative care. It's really about all those supports that help you have a meaningful, full life until the very end. So just even destigmatizing it, it's not a death service. Even in the physician community, it's still misunderstood.
Great, thank you. I'm keeping an eye on the chat, and I am just continuing to see great comments and questions from people. I'm going to read a couple of them again just to get them on the record here, so it's on the recording to hear these perspectives. Gioia says, I hope I pronounced that right, I think that's why the trope of disabled people all having miserable lives is so damaging, and why the inspirational disabled person trope is too. Nobody should have to feel like they need to prove that their lives are worth defending. That got some positive reactions in the chat and with our speakers. Beth Fox again says, it's not ableist to tell people that their life is valuable and worthy of living, to encourage them to keep going. There are definitely elements of the disabled journey that an able-bodied person can't relate to, and you shouldn't try to compare struggles, but maybe you can help them find that peer support or the resource they need, or maybe you can urge them for treatment for those suicidal thoughts, just like you would for an able-bodied friend. And Amy Murphy, another Rehumanize team member, says, the inherent ableism of thinking that disabled lives aren't worth leading, so offering assisted suicide is automatically is grotesque. And so I very much appreciate the active chat going on. Please continue posting in the Q&A as well. One more question from Q&A. Do you think that part of the reason MAiD and assisted suicide are pushed so hard is because we have forgotten that disability and death are a natural part of the human life cycle? Maybe because institutionalization and nursing homes and the medicalization of death has removed us from the reality of death. Taylor, you are nodding hard. Do you have an answer, as is Dr. Jans?
I mean, the currently institutionalized one has to say yes to this. We are removed from even the natural is the wrong word, but the kinds of disabilities that we're all going to fall into as we age. And unfortunately, some of the institutions that are set up to help people thrive in these new states, they either dismiss where people are at. You can't do such and such because you're too old for it, instead of providing people the tools to allow to participate in more aspects of life safely, or they, like the center I'm in right now, there's a lot of, you can do it, and perseverance and mind over matter, and that's that's great, but that still doesn't change the need for tools and innovations to help me thrive where my body is currently at. It's not always something I have control over. And to be able to need or use supports doesn't mean I'm trying any less hard, doesn't mean the way I live my life is any less worthy than someone who doesn't use any tools.
Great, thank you. Dr. Jans?
In my daily life,
In my day job, I teach physicians about disability ethics. And one of the terms that I teach them is task. Temporarily able bodied. Meaning if a person lives long enough, they will acquire some form of disability. And then I tell them that I am their worst nightmare. Because I need help to use the washroom.
But when they
lose their tab status, so will they. And for them to assume that when they get to the point when they need somebody to help them wait, that their lives won't be worth anything. They devalue. They devalue all the lives of their patients.
And that makes them jaws drop.
And that makes some jaws drop.
Thank you. Well, this has been just an amazing, amazing session. We are running out of time, and so I want to quickly go around and allow everyone to share last thoughts, impart some final words of wisdom on our attendees and the future people who will watch this video perhaps one day. And also, please take an opportunity to plug any books, Twitter accounts, upcoming conferences, Nicole, that you'd like to let our attendees know about, and we can also send that information out. So let's start with Taylor, and then we'll go around for final thoughts.
Parting words of wisdom to leave you all with. I think I've gotten most of it out of my system, I'm afraid.
Okay.
Definitely check out organizations like Not Dead Yet and other places that are... Sorry, I've completely lost my words.
You are fine.
If you're interested in doing more research on this issue, please make sure it's led from the perspective of people who actually live with the conditions and supports identified. Not their parents, not their doctors, sorry, Nicole, and not their caregivers. There is way too much information out there that talks about disabled people without involving us. And that's exactly where you get the mindsets that lead to the end of a needle that we've all told you about today.
Great, thank you. Nicole, how about you next? I know the conference is coming up.
Yeah, sure. So we have a conference in 2 weeks, Canadian Physicians for Life, and you can attend online if you can't get to Saskatoon. It's live streamed, and then also you can have access to the videos. But I would say the one thing that occurs to me is that it's arrogant for us to think that we don't need each other. I mean, if any of us were put in by ourselves in an island or even alone in a city where you didn't know anyone or couldn't speak the language, you would be in a sense disabled. You would not be able to operate the way you typically think you could. And so you have to have a certain level of humility about that and realize that for any one of us, this idea of autonomy or being able to do everything yourself is somewhat of a facade. And from that, I would say to take a certain level of tenderness towards people in our communities that need more help than we currently do. You may be at a point in your life where you don't need help, but at some point in your life you will. And so to extend that hand of tenderness and generosity and find a way to become a friend to people who need more help than you currently do. And I think that's a great way that we could make our communities more caring and compassionate.
Thank you. Dr. Herx, you're up next.
I'll just build on those wise words from Nicole, but so many, at least in Canada and probably consistent internationally, people request euthanasia because they feel their life doesn't have meaning or they're not able to do things independently, that they've lost that sense of autonomy. That I think we need to work on shifting our culture, that our lives are not, the value of our lives is not by what we can do, right, or not do, and that doesn't change as we age or develop our disabilities, as we're all going to do in our lives. And so just that inherent value of a person needs to be reaffirmed in our communities, again, that grassroots level. And Nicole actually brought this to me through the conference a couple of years ago through Carter Sneed's work of looking at this idea of uncalculated giving, where we just care for one another. But the other part that I find actually harder for us is the gracious receiving, that we ourselves are all worthy of receiving care as well, and we all need care in our lives. So I think that really fits well with the compassionate communities movement and what we're talking about today, to really promote on our day-to-day basis, we can all make a difference with that idea.
Wonderful. Thank you so much. And to close us out, parting thoughts from Dr. Heidi Jans.
Well, the father among the media that
Well, the picture on my media, social media, my main picture says autonomy is BS.
and that will always remember.
And that's what we need to remember.
We are all interdependent.
We are all interdependent.
And we all need one another.
And we all need one another.
Regardless of status, ability, or
Whether we're in a state of ability or disability,
we need each other.
we need each other.
Well, thank you all so much for joining us for this panel. I know that this has been impactful for all of our attendees, and I am so grateful for each of you for all of your advocacy here and out in the world. So thank you again so much. You are free to go.